Moving into our first section, we'll talk about embryology. And with embryology, throughout NPLEX, oftentimes it's not on there at all with any questions, or it's on there in such detail and depth that it's not even reasonable to know. One of the more significant embryologic sections is cardiovascular embryology. And so we are going to spend a little bit more time here than we might in other organ systems. So remember, the cardiovascular system is the first organ system to function when an embryo is developing, and it begins forming around week 3. And the key kind of reason why it starts forming so quickly is because the embryo really quickly outgrows the ability to receive nutrients by diffusion, so it needs to have its own ability to circulate nutrients throughout its growing body. In week 3, you'll see mesoderm. That's the type of germ layer that the heart and blood is derived from. The lateral portion, the lateral plate of mesoderm, gives rise to angioblasts. Angioblasts are blood islands. You could think of them as leading to angiogenesis, right? The generation of blood vessels. And also at this time, we'll see our two endocardial tubes. They will fuse together to create our primitive heart tube. In week 4, we start to see this kind of twisting nature that the heart tube loops and it establishes the left to right side of the heart. Then later on, we'll see between weeks 4 and 8, there's the septation of the chambers and the formation of our valves. And then by week 8, our fetal circulation is pretty much established. So let's look at the heart tube first. At week 3, we have our two endocardial tubes. They're bilateral. They fuse together to create the primitive heart tube at week 3. They create 4 significant regions going from cranial head to caudal tail. We have the truncus arteriosus, the bulbus cordis, the primitive ventricle, the primitive atrium, and then not shown here, but kind of at the bottom, we can see this here, this part, the sinus venosus. So truncus arteriosus, bulbus cordis, ventricle, atrium, and sinus venosus. These all give rise to these mature heart structures. So their truncus arteriosus, this would be high yield, is our ascending aorta and pulmonary trunk. The bulbus cordis is our right ventricle and outflow tracts. Our primitive ventricle is the left ventricle. Primitive atrium is both left and right atria after septation, and the sinus venosus is our SA node, the coronary sinus, and the smooth portion of the right atrium. Now, during week 4, we have also to take this straight tubal structure and we need to loop it and to create symmetry and actually what the adult heart structure looks like. And so it does this D loop or dextral loop, which gives us the left-right asymmetry of the heart. And if this fails, situs inversus or hexrotaxy can occur. These both are not on your rubric for or your blueprint for NPLEX. I wouldn't worry about knowing them. When we think about septation, the separation of the two atria, it starts in week 4 and ends around week 7. And we start with this endocardial cushion here. This endocardial cushion is kind of a starting point. We'll talk about it later. They're essentially just masses of extracellular matrix that are lined with endothelial tissue. So this endocardial cushion is located, and we'll start to first see the septum primum is going to grow down from the roof of the primitive atrium, and it's going to grow towards the endocardial cushion. The initial opening between the septum primum and the cushion is called the ostium primum, and this again allows for right to left blood flow. The ostium primum will start to close as the septum primum meets the cushions, and there will be a perforation in the upper septum primum, which is the ostium secundum. We can see that here. And the septum secundum grows then later right over the top of the septum primum. We can see this yellow structure. And this does leave a hole. And this hole is the foramen ovale that allows for right to left blood shunting during fetal development to allow for bypassing the lungs. After birth, the left atrial pressure increases, pushes back against these structures, and seals the foramen ovale. And what we have left over is just the fossa ovalis. In the ventricles, we have our muscular interventricular septum will grow upward from the apex. The membranous portion is the last portion to close, and the endocardial cushions and truncal ridges help that membranous portion close. If it doesn't close completely, we can see a ventricular septal defect or a VSD, which is the most common congenital heart defect. Our atrioventricular valves also are formed from the endocardial cushions, and like I mentioned, Kind of talked about what these are, but they form at the AV junction between the atria and the ventricles. They undergo a transition from epithelial to mesenchymal, so epithelial to mesenchymal transition to populate the cushions. The superior and the inferior cushions fuse, and that divides the atrioventricular canal into right and left openings. And then remodeling occurs. And the remodeling gives us our tricuspid valve on the right and our mitral valve or bicuspid valve on the left. We'll also see that from the ventricular trabecula, chordae tendineae and papillary muscles develop. Our semilunar valves come from truncal and bulbar ridges. Truncal ridges kind of spiral within the truncus arteriosus, and that divides the truncus into the aorta and pulmonary trunk. And then swellings beneath the truncal and bulbar ridges give rise to the three cusps of each semilunar valve. It gives us the pulmonic valve or pulmonary valve on the right and the aortic valve on the left. A bicuspid aortic valve is failure of one of the cusps to divide, and it's another really common congenital defect. It's the most common congenital valve defect. And truncus arteriosus, or a persistent or patent truncus arteriosus, is the failure of our truncal ridges to divide. Thinking about developing blood vessels, we have the process of vasculogenesis versus angiogenesis. Vasculogenesis is the de novo formation of blood vessels from these angioblast cells, these mesodermal precursors, versus angiogenesis is formation of new vessels sprouting off of current or stable vessels. Another component of the heart is the development of the aortic arch. So this is kind of showing our aortic arch structures. There are 6 pairs of aortic arches that form and remodel during weeks 4 through 8. The first and the second arch largely regress. The third arch is going to form the common carotid arteries and the proximal internal arteries. So we can see common carotid here, and then our internal and external. So external and internal. The fourth arch on the left becomes the arch of the aorta. On the right, it becomes the subclavian artery. So arch of the aorta, subclavian. Arch 5 pretty much regresses. Arch 6 will become the pulmonary arteries. Arch 6 on the left also forms the ductus arteriosus, which is going to go away and be kind of a remnant. So this is kind of the different arches and development of blood vessels, or how we get the blood vessels that come off the aorta that we learned, our ABCs. Now, I already mentioned a couple fetal shunts, and we talked a little bit about what happened to one of them. Our foramen ovale gives us a right to left atrial shunt, and it becomes the fossa ovalis. The ductus arteriosus connects the pulmonary artery to the aorta, and it becomes the ligamentum arteriosum. The ductus venosus bypasses the liver, and it becomes the ligamentum venosum. And our umbilical vessels close after birth, and they just become ligaments. Fetal circulation receives oxygenated blood from the placenta via the umbilical vein, and the ductus venosus will shunt blood past the liver directly into the IVC. Oxygenated blood then will flow through the foramen ovale into the left atrium, left ventricle, and the rest of the body. That's its preferred direction. And deoxygenated blood from the right ventricle shunted past the lungs via the ductus arteriosus, and then moves directly into the descending aorta. Lungs only get 10% of cardiac output in utero. There's higher pulmonary vascular resistance, and it's not a functioning tissue yet. So there's really not a large need to oxygenate them as we would when we breathe. When we have our first breath after birth, it expands lungs and drops the pulmonary vascular resistance pretty dramatically. We'll see an increase in left atrial pressure, which will close the foramen ovale. The functional closure happens immediately, but the anatomic closure happens over weeks. It will seal off. Increased oxygen tension and decreased prostaglandins lead to the closure of the ductus arteriosus, and umbilical vessels will constrict as the placenta separates. Now, we can have a patent ductus arteriosus, which is a failure of the ductus arteriosus to close, and that's a left to right shunt, so different than some of the others. We can also have a patent foramen ovale, which is an incomplete anatomic closure, which is found in about 25% of adults. Typically, this is asymptomatic. We're going to stop here. When we come back, we're going to lean into muscle contraction.